Hi, I'm Angela Wilson-Liverman. I'm a certified nurse midwife, and I'm here to answer your questions about midwifery from the internet. So the first question is, are midwives still a thing? That's a funny one. I get that one sometimes. Midwifery is the second oldest profession in history. If you know what the first oldest is, babies are made and someone had to deliver them. So yes, we're still a thing. Actually, midwifery is growing in the United States. I think probably somewhere about maybe 10% of babies born are born into the hands of midwives in America. Okay, the next question is, what is midwifery care? Midwife means with woman, and so midwifery care is just care of women throughout the lifespan, typically from puberty on really through death. We often think of midwives associated with childbirth, but midwives care for women through all phases of life. So, cancer screening, pap smears, that kind of thing, contraceptive needs, of course, pregnancy care, well woman care like annual exams, and then also menopause care, perimenopause and menopause. So midwives are kind of like soup to nuts. They take care of women throughout the lifespan. The next question is, are midwives and doulas the same? The short answer to that is no. Midwives are trained professionals with a specific educational requirement, at least a master's degree, often in nursing, sometimes in midwifery. Many midwives now also have a doctorate, but most are licensed differently state to state, but often as an advanced practice professional, like a nurse practitioner. And then they have, privileges to admit to hospitals, to be reimbursed by third-party payers like insurance companies, to have privileges to be able to write prescriptions, to have a DEA number, to be able to write controlled substances, that kind of thing. Doulas are labor support and home postpartum support people. So they do have training, but there's not a specific educational requirement, and they're not typically paid by insurance companies. They don't do medical things. They don't deliver babies or write prescriptions or, do pap smears or do stitches or those kinds of things. The next question is, how do you become a midwife? There's a lot of different ways to become a midwife and not just one particular path. In my case, I'm a certified nurse midwife, so I did have a degree in nursing before I went to midwifery school, before I went to midwifery training. Other states, you don't have to be a nurse, but like I said, you always, to be a certified nurse midwife or a certified midwife in some states, you at least have to have a master's degree and then sometimes a doctorate. There's national certification exam and then state licenses that go along with it. Minimally, kind of, like I said, master's up to doctorate. Most midwives have somewhere between 6 and 12 years of postgraduate training. Next question, do midwives only do home births? No. In fact, probably 95% of births that are attended by a certified nurse midwife or certified midwife are done in hospitals or in birthing centers. There are a few certified nurse midwives who do home births. Most of home births are done by other types of midwives. So I would say that by far, home births are the exception for midwife-attended births in this country. Next question, are there any midwives who are men? Short answer, yes. Midwife means with woman, but there are male midwives, and a lot of them historically came through the military. The military trains a lot of advanced practice professionals, and so there might have been nurses, labor nurses that were in the military and then pursued, additional training to become midwives. But now when you look across programs, there are more men enrolling in midwifery programs. We just had a male student in the last group of students that we had. So definitely more male midwifery students and more male midwives. Certainly the bulk are women, but more and more male midwives. What are the benefits of midwifery care compared to traditional OBGYN care? So in comparing midwifery care to when you say traditional OBGYN care, midwifery care in general is approaching the care of the woman in a more of a holistic manner, seeing most phases of health as just that, like a phase of health, whether it be reproductive, going through puberty, pregnancy, menopause, and framing it, looking at things from conditions that are normal in the lifespan and seeing them from that angle rather than like a disease process to be, cured or fixed. But I will say that there really is only one standard of care when you're talking about caring for women who are pregnant or women who are birthing. There is a standard of care. It's not that midwives are delivering some lower standard and doctors are delivering a higher standard. That's not the case. If someone has high blood pressure, for example, midwives are trained to recognize that and to deal with that, just as you would expect a physician to recognize it and to deal with it. So I would say, in general, just a little bit more comprehensive and holistic. What happens if complications arise during pregnancy or birth? So a little bit of a segue from question 9, the same. Midwives have at least a master's degree, if not a doctorate, as I alluded to in the prior question, are trained to recognize deviations from normal. So whether it be complications with the baby, like baby growth issues or anomalies or things with the unborn child versus the mother herself, like blood pressure issues or diabetes, those are conditions that are tested for regularly in all pregnancies. And the midwife would be expected to recognize them, to treat them, or to refer the woman appropriately to a physician if that's what she needs at that time, whether it be during pregnancy or during labor or birth. If anything arose that was outside of the scope of care of the midwife, then she would involve a consulting physician or transfer the care of the woman herself to a physician if it needed that. What does a glucose test look like with a midwife? So a glucose test looks the same with a midwife that it looks with any other obstetric provider. There are some alternative ways of doing the glucose tests that have been, published in the literature, which involve a different, basically, source of glucose. There are tests that involve jelly beans or like a Snickers bar or whatever. I don't think that most midwives are first line doing that as the way that they test their patients, but maybe if a patient can't tolerate the glucola or it makes her nauseous or something like that, then the midwife might look into an alternative glucose source to get that 50-gram load. How often will I see you during pregnancy? For traditional midwifery care in an outpatient setting, the cadence or the frequency of visits is similar to what it would be with an OBGYN. The accuracy of a first trimester dating ultrasound is absolutely the best, and the further the pregnancy progresses, the ultrasound is less sensitive and less accurate as far as the dates go. So we like to see people early, and also that's when we offer genetic screening tests and also carrier testing for other conditions. So first trimester, and then often again in the middle, around 16 weeks. Then around 20 weeks, we see women and we do the big anatomy ultrasound. So they have a visit anatomy ultrasound. And then about once a month until we get to around 30 or 32 weeks, and then every couple of weeks until about 36, and then about every week after that. So depending on a woman's comorbidities, does she have other medical problems or not? We might see her more frequently, but I would say on average somewhere between 8 and 12 visits across a typical pregnancy, assuming the mom enters care in the first trimester. What should I do if I go into labor early? Anyone, regardless of whether they're seeing a midwife or a physician or whomever, if they start to have labor symptoms, at any time they should go to wherever it is they plan to deliver, so their closest, hospital, obstetric unit or whatever, and get checked out, see if it actually is labor. They would put you on a monitor. They'll see what your contraction pattern looks like. It would typically involve a cervical exam. That's when we do a digital exam to find out if you have cervical dilation. We would check to see if your water is broken, if you're having those kinds of symptoms, and also to do some testing on the baby to make sure that the baby is doing fine and healthy and all that. If you wind up being in preterm labor, then typically you would be kept at the hospital. Whether or not you deliver early is a matter of the wait and tell kind of game. And if you were just having contractions but not dilating and not actually laboring, then you might actually wind up getting sent home if you weren't actually in preterm labor. What is morning sickness? Morning sickness is basically kind of the, colloquial term that we use for nausea in pregnancy. It is certainly not isolated to the mornings. It is often associated with increasing hormone levels that the mother is experiencing as the baby is developing, specifically the increased progesterone levels. Morning sickness is often the worst in the first trimester, and that's because the embryo itself is producing progesterone, and those increasing levels of progesterone make the mom feel nauseated. By about 12 to 13 weeks, the placenta is formed and the placenta takes over progesterone production. And so typically after the first trimester, there isn't as much circulating that progesterone effect in the mom's bloodstream. And so she doesn't typically feel as nauseated after the first trimester. with the exception of women who unfortunately can have a condition called hyperemesis gravidarum, which is where they have really terrible hyperemesis, just means like extra, nausea, vomiting, throughout the pregnancy. And people can be very badly affected and have to have IVs and medication for their nausea, sometimes even requiring hospitalization. Fortunately, that's the exception and not the rule. But most women experience some type of morning sickness, whether it be just a little bit of nausea or actually vomiting sometimes during the first trimester. Next question, how can I manage morning sickness? It takes a lot of little changes, multiple things to kind of get on top of it typically, and not one magic bullet. For example, eating smaller meals more frequently. In other words, not having much time elapse between meals. That's why historically people said morning sickness, and it was often because they had been asleep or gone a long time without eating, and then they wake up, their blood sugar's very low, and then that starts that cycle. The blood sugar's low, they feel nauseous, they can't eat, then they don't eat, the blood sugar gets worse, they vomit sometimes or whatever, and then they really can't eat, and you become dehydrated, and it becomes like a kind of vicious cycle. So small, frequent meals, certainly sipping on things throughout the day. I often recommend sipping on things like lemonade, something that's got lemon can be helpful for people. Ginger can be helpful for some people, so they might like ginger ale, they might like a ginger tea, or even just to put some ginger into something else. Sucking on hard candies can be helpful, like mint. A lot of people mint helps them with their nausea, so sucking on like a peppermint candy or even like a lemon drop can be helpful. If that's not doing it, some people can wear C-bands. Those are those like pressure point things that help people not get nauseous like when they're on a boat. And then we have other prescription medications that your midwife or obstetrician could prescribe for you if you are getting into this cycle where you're actually vomiting and not able to keep meds down. And if it's really bad, then if you go a full 24 hours and haven't kept any liquids down, you need to call and be seen because you might require some IV rehydration. What helps with anxiety during pregnancy? That depends on where the anxiety is emanating from. If you are someone who has a diagnosis of an anxiety disorder, like generalized anxiety disorder, then that's something that you need to stay in contact with whoever your mental health care provider is. If you are on medication for anxiety, then we definitely don't want you to stop that cold turkey when you become pregnant. Hopefully you would have discussed that prior to becoming pregnant with your mental health provider to see if the med that you're on is safe during pregnancy. There are other strategies if you're feeling a little bit anxious because of worrying about a baby or worrying about being off work or finances. That's a little bit of a different thing. And certainly, we recommend that people, do the things in pregnancy they would typically do when they're not pregnant. Meditation, yoga, exercise, a lot of these things are very helpful for people just kind of keeping kind of a general wellness. I would tell people to not avoid seeking care if they have a tendency to be actually medically anxious, so that they definitely want to have that in good control before they have a baby and then go into the postpartum period where they're more at risk for depression and worsening anxiety. Okay, so the next question is, what are the benefits of taking prenatal vitamins while pregnant? Prenatal vitamins are more of replacement than anything else, with the exception of probably folic acid. Folic acid, we know, prevents the formation of a neural tube defect, and that has been demonstrated. So those are things like spina bifida. Probably in the late 80s, early 90s, we started recommending that moms supplement with folic acid, and a minimum of 400 micrograms a day of folic acid. Now, things like orange juice and whole grain cereals and things like that are fortified with folic acid, and so the incidence of neural tube defects has drastically diminished since that recommendation and that fortification has come out. But other things that are in prenatal vitamins, like the calcium in the vitamin and things like that, those are replacements to the woman herself. So the baby will typically get what it needs, including, breaking down the mom's bones to get calcium to make baby bones. So then later on in the woman's life, if that has happened when she's pregnant, if she didn't have enough calcium intake when she was pregnant or supplement with calcium, then she might have osteoporosis or have issues with her bones later. So most of the time, what you're doing with the prenatal vitamin is ensuring that you are basically replenishing what the baby is needing to make its muscles and bones and all those kinds of things. Prenatal vitamins also often have iron. And so if women tend to be anemic, which means like low levels of iron in their blood, the iron can be really helpful in replenishing that. And then, of course, there are a host of other, vitamins and minerals in a prenatal. But usually the thing that makes the prenatal vitamin be big is the calcium. And so if people are having difficulty swallowing a big prenatal vitamin, there are options without calcium, and you can do the calcium separate. There are also gummy options or chewable options where you can kind of like split it up throughout the day. The important thing is you don't want to take a prenatal vitamin with food, and you don't want to take, if you really need the iron because you're anemic, you want to take it with vitamin C, something like orange juice or apple juice or tomato juice, but not milk, because calcium will interfere with the absorption of iron. So the benefits, like I said, are mostly towards the mom later for replenishing her stores. All right, next question. Can I drink alcohol while pregnant? So the easy answer to that is no. There's no established safe amount of alcohol in pregnancy. We do feel that from studies, the condition known as fetal alcohol syndrome, which is a established diagnosis, is associated with chronic use of alcohol. So pretty much like daily alcohol intake is what is leading to that condition. But we really don't know what the thresholds are. There will never be a study where they're going to give women like alcohol on some random, basis or amount to try to see if her baby has, a problem from it. So the safest thing is to avoid all alcohol, tobacco, and drugs during pregnancy. Next question is, can I drink caffeine while pregnant? The answer to that is yes. We don't recommend that people, abruptly stop caffeine for a few reasons. One, caffeine for a lot of people helps them in the morning, like with going to the bathroom. Pregnancy slows down gastric motility, as do prenatal vitamins. And so for people who are pregnant, they start a vitamin. If they abruptly stop their caffeine, they may really have some rebound constipation, which can be pretty unpleasant. Also, the estrogen levels of pregnancy can have women getting more headaches. Caffeine can also help with that. So most things in pregnancy are about moderation. So should someone drink a pot of coffee in a day when they're pregnant? Probably not, but 1 or 2 servings, like 1 or 2 like normal size cups of coffee or a soda, probably completely fine. We don't recommend cessation of caffeine. So the next question is, how much weight should I be gaining for a total pregnancy? Pregnancy is 40 weeks, 280 days. It really depends on the woman's starting weight, starting BMI, kind of what the recommendation is. In general, about 20 to 25, 30 pounds is sort of the normal range. We usually say, 10 pounds by about 20 weeks, and then the remaining weight, over the next, so another 15 or 20 pounds over the next 20 weeks, because obviously in the beginning, the baby's way tiny. So as the baby starts to really put on weight in the second and third trimester, then that's when most of the weight gain happens. If a woman is very overweight, so if she's starting with a BMI that's in the obese range, then she may only gain 10 or 15 pounds. If she's very underweight, she may need to gain more like 35 to 40 pounds. I would definitely talk to your OB provider, your midwife, about that, about recommendations. The main thing to remember is that we can monitor baby's growth and baby's weight with ultrasound now. So if you are someone who started out very under or very overweight, then you probably will receive more ultrasounds to sort of monitor the baby's weight. What we don't want people doing is really dieting during pregnancy. We don't want people to be in ketosis or really burning their muscle or fat during the pregnancy, for energy. So definitely a scale there for what's normal. The next question is, can I exercise while I'm pregnant, and what kind of exercising can I do? And so the answer is yes. Of course, you can exercise during pregnancy. For the most part, the things that you did before you were pregnant are okay to do when you are pregnant. We don't usually recommend that people take up a new intense exercise regimen, like high impact aerobics, for example. We don't recommend that women elevate their core temperature to over fever level. So hot yoga might be too much, or get their heart rate over about 150 to 160. If you're someone who, your exercise regimen involved things like horseback riding or skydiving or scuba diving, then those things you might want to avoid. But that's not because of like the risk of the actual thing to the baby. It's the risk of like falling, or it's the injury that might happen while you're doing it, not the act of doing it itself. But normal things, low impact aerobics, exercise, stretching. We don't usually recommend after the second trimester that people are doing a lot of like ab work, like doing a lot of like crunches and stuff, because the baby's growing and expanding like through the abdominal wall, and those muscles have to sort of separate for the uterus to grow. Other things that walking, swimming, those kinds of things are all great, and we want people to do that. We want them to be in good aerobic condition when they come into labor. The next question is it safe to travel while pregnant? Short answer to that is yes, it's safe to travel. You can pretty much travel when you're pregnant just like you do when you're not pregnant. The issue with travel and why you hear about it is because later in pregnancy, as you get further along in the third trimester and closer to your due date, there's always the risk that you could go into labor. And so when you're making a decision about travel, especially in the last month of your pregnancy, you have to weigh the pros and cons to you and your family. How much of a disaster would it be to you and your family if you went into labor in St. Thomas or in, wherever you're going to go. A lot of times people are traveling because there's been some family event, a death in the family, a wedding. And so I think you have to, sometimes those things are worth, the risk for a couple of days to be gone and to take the chance of going into labor somewhere else. I always recommend that if someone's traveling in the third trimester or beyond, that they have access to their prenatal records, basically. So a lot of times now, people have it on a portal. They might be able to get onto an app and see their, records. Like here we have My Health at Vanderbilt, and people can see all of their labs and their ultrasounds, and they can really even see it like on their phone. But if that's not possible for you, or if you don't have that sort of situation, you can always have your office where you get OB care print out the summary of your pregnancy record. That would be like your prenatal labs, the ultrasound that established your dates and your anatomy scan, and any just sort of the highlights of your care, problems and things like that. And carry it in your purse just in case you were to have any issue. Then you would have it with you if you went and presented to some OB unit that wasn't, your normal location of care. I would say as a caveat, when we talk about travel in general, that long periods of sitting when pregnant, just like when you're not pregnant, but a little bit more so, you have more of a risk of a blood clot or of like a urinary tract infection from being really sedentary. So if you are going like on a flight over the ocean, or you're going on a car ride to California or something like that, you should at least get up about every 2 hours, walk around, make sure you're drinking lots of fluids. Don't avoid drinking because you're going on a long trip. You want to drink frequently, you want to empty your bladder frequently, and you definitely, at least every couple hours, want to walk around. And that just helps minimize the risk of like blood clot or urinary tract infection. Next question, do specific foods help induce labor? That's a funny one. And also, I wish that we knew what that was, because we'd all be feeding it to everybody. We'd be like having it up on labor and delivery, like we'd be serving it to people that we want to go into labor. But the short answer is no, not that we know of. There are tons of, urban legends and myths about, I've heard people talk about eating like particular like pineapple or spicy foods, or this particular like Thai dish that's like super spicy. If you've had friends that ate that and they went into labor, it's probably not going to be harmful. Try it, but there's definitely no, published evidence that there's a particular food that would help someone go into labor. All right, the next question is, what are the benefits of a water birth? Water birth is a thing where the baby's actually born in the pool of water. So the baby like comes out in the water. There's also the more common practice of using hydrotherapy or water for labor. And so I would say there are lots and lots of hospitals, and probably every birth center, that uses hydrotherapy for labor, where you can get in a tub, during the labor process. There are fewer places that actually do water birth, where the baby is being born into the water, including here at my hospital, at Vanderbilt Hospital. We don't do water birth. We have tubs for labor. So when birth is imminent, then we have the mom get out of the tub and get like wherever else she wants to be, where the baby can be born safely. Our birth center, the Vanderbilt Birth Center, does offer water birth, and they have tubs in all their rooms. So that's a great option. I think that when people talk about the benefits of water in general, whether it be for labor or for birth, It's the analgesic effect, just like why do people love to get in a tub? It's relaxing. There's buoyancy or weightlessness. So people who already feel like heavy and uncomfortable and bloated, the water can just provide that relaxation and that feeling of weightlessness. Also, if if there's temperature, that can help with muscle fatigue, with the pain of the contractions. If there happen to be jets in the tub, the jets can be very, relaxing and therapeutic on people's, back muscles, belly muscles, that sort of thing. And I think on the area, if the baby's actually being born in the water, the same thing. It's just the feeling of the water is just very calming and comforting. What are must-haves for your hospital bag? I mean, we probably overdo the hospital bag. A lot of people nowadays are ordering fancy, labor gowns and, things like that for themselves when they're in labor and, matching stuff for the newborn. I would say if you want to order cool clothes, order them to have later, when you're at home, because especially in labor, they're going to get really messy and potentially ruined. Labor and birth are kind of, there's a lot of fluids, blood, messy stuff. And you don't want that to get on really, cool stuff that you invested a lot of money in. So I would encourage you to use what the hospital provides and save your nice stuff for labor, but you do what you want. I mean, that's everybody, to each his own. Definitely bring the things that you really need. If you wear contacts, you need contact cases, solutions. The hospital, while you're here, is going to put diapers on the baby, and they're going to wrap the baby and swaddle them and put them in a gown. So you don't have to provide the clothing and the diapers for the baby while they're at the hospital. You certainly are welcome if you want to have a special outfit for the baby to go home, pack that. We will also provide pads, peri pads for you for after the baby's born, and also the little mesh underwear. All of those things are included in your hospital, kit. You probably do want to have, something to wear home. Make sure, slip-on shoes are more, easy to get in and out of. If you're having a cesarean section and it, bring something that buttons up maybe, or slip on, sweatpants, or something that's really easy and loose and that you're not having to worry about fitting or not fitting. Don't expect that after you have the baby that your body is going to be the same size as it was before you were pregnant. The uterus still has a lot of shrinking to do, but just things as far as must-haves, just your toiletries that you really need in the bathroom that are yours specific. Like I said, if there's something with your eyes, maybe an extra pair of glasses, if you're a contacts wearer. If you have piercings and things like that, you might want to go ahead and take that stuff out and put it, in a safe place, and maybe even leave it at home. You probably want to bring a phone charger, I would say. Most people have their phones and they want to be able to text, so bring your phone charger, and then just the things that are specific for you, like I said, that you might need if you wear a retainer at night or those kinds of things. All right, the next question is, any advice for how to be a supportive partner to those in labor? I definitely recommend for first-time parents and partners that taking a class could be super helpful. The Vanderbilt Birth Center has great classes. There are online classes that you can get. Lamaze is great. Hypnobirthing is great. I think all of these types of classes are great because they do teach you really what to expect, and then also how to be supportive. The main thing I think for being supportive is listening to the mom, kind of advocating for what she wants, and remembering that this is a dynamic process. And so although you probably have perhaps worked on a birth plan or ideas of what you want, this is a natural process, and so things can change. So being resilient, being flexible, being open to listen and advocate for your partner, but also help support her if there are deviations from the original plan. Her comfort, I think most people know what their partners like and don't like. Some people love to have their back rubbed. Some people hate it. Some people love to have their feet, massaged. Some people are super ticklish and don't want you to do that. So I would say anything that your partner likes or doesn't like when they're not pregnant or not in labor, it's probably gonna be magnified. So they're gonna really hate it when they're in labor, or really like it even more. In the beginning, if you know that you have to be induced, or she has to come in for a while and is gonna be here before the baby comes, something, maybe some music or some games or something that you like, just to pass the time. But also, just like I said, being resilient and listening, to her. If she's saying, I need, I want pain medicine, or I want to see my midwife right now, speaking up on behalf of her, and probably not trying to change her mind or argue with what she's asking for, because things change moment to moment in labor. So the next question is, do more women go into labor during a full moon? So this is a debatable question. I personally don't think that there's evidence that we have more babies on a full moon, but I work with a lot of midwives and labor nurses who absolutely would disagree with me. It's something that I think maybe we should go back and pull those numbers here and see if we do have more babies like during those times. What I will say that I believe is backed up by science is that when a storm system is approaching, so like a low pressure system, that we have more women go into labor. Specifically, we have more people who their water breaks. And that makes sense to me, like, atmospherically, like if the pressure on the outside suddenly drops. And so I used to work in Florida, worked during hurricanes. We definitely had more people come in with their water broken. And when we've had big storm systems here where it's like fine, and then all of a sudden you get this really like significant cold front or rainy front or whatever, it seems like we definitely, we have more people come in and their water has broken. So I'll go with the low pressure. I'm not sure I'm going to go with the full moon, but all the midwives out there who are watching are be like, she's crazy. Clearly we have more babies on a full moon. What do you recommend for a birth plan? In general, I always tell people for a birth plan, keep it clear. I recommend keeping it to one page. There are lots of websites, and if you go onto websites about birth plans, you are likely to get these birth plans that print out and are 5 or 6 or 7 pages long. And so I tell people, if it's something you've never thought about, don't include it in your birth plan. Include things in your birth plan that really matter. I want my husband to be in the room. My husband absolutely does not want to cut the cord, or does. I absolutely don't want my mother-in-law in the room, or whatever. Whatever is specific to you and things that you really care about, include that in your birth plan. Because I will tell you, and I'm at Vanderbilt, we're pretty progressive. Our normal care is what a lot of people, skin to skin, all of our babies go in the mom's belly if they're healthy and term and crying. We delay cord clamping for all births. That's been a recommendation for a long time. So our babies are on the belly, the clamping is delayed. So if there's something really unusual, then, ask that. The next question is, should I eat my placenta? I would say definitely no. I don't recommend that. That practice is called placentophagy. You've probably, some people say, well, it'll help prevent postpartum depression because, of the whatever's in the placenta. But if you look at like humans throughout time and even before like written time, there really is no historic precedence for humans or eating their placenta. You probably see that in other animals. And so people are like, oh, well, dogs do it, like clearly we should do it. But there are risks to that. There could be like infections. Some people have heard of like prion disease or mad cow disease. There are some reasons to avoid eating things that come out of your body. And the main thing is we just don't have any evidence to support the claims. There's no real evidence that eating your placenta has any impact on postpartum depression rates or mental health in the postpartum period or other things. So we don't encourage people to do that. All right, that's all the questions we have for today. Hope they were helpful. Thanks for listening.